Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are bringing the BOC to real life.
I like that.
Thank you.
I mean, technically, that is what this is called, BOC IRL, BOC in real life, but it sounded really cool when you said it.
Oh, thanks. I just, ran with what was given.
So I went kind of bold and broad with this episode, and we are talking about rehab as a whole. So if you are new to this BOC IRL format, anyone can listen to it, although it is targeted for people who are trying to pass the BOC or trying to review, I guess, for the BOC, but also anyone who just wants to review any of these topics. I think it helped me review a lot, honestly, because sometimes going back to the book is like just going back to your basics.
Yeah, for sure.
This episode is brought to you and sponsored by ATStudy Buddy. They have over 50 athletic training programs and thousands of students with them nationwide studying for the BOC.
That's dope.
And they have over 250 resources, which is a lot more than we have. So if you are studying for the BOC, this is a great online BOC exam prep platform. And it's also built by athletic trainers.
I think that part is what makes it really special.
Right. This is something that like we really look for, and when we're looking for like products or whatever we're working with, we really like the athletic trainer background. But yeah, they have full-length practice exams, domain-specific tests, modules by topic, and study guides. My favorite part and Randy's favorite part, interactive games. Like they do like fill in the blank, word search, like matching, and while you're studying.
Yeah.
So obviously, if you're here, you're trying to find a different way to study. ATStudy Buddy does it right.
Yeah, for sure. I think one of my current students is using it.
Oh, sweet.
For their study, and I think so far they've liked it.
Yeah, that's awesome.
Yeah.
We've got to play around with it a little bit, and we liked it too. So, if you would like to try it out, there is a free 2-week trial. And if you're just sold right now, go ahead and use code ATCornerStudent to get 10% off your monthly subscription price.
Nice.
So with that, we are doing rehabilitation this week. I forgot that was right there, and I was like, what are you doing? Yes, that definitely deserves a reggae horn. But just starting generically, what is rehab? So rehab is after injury, we're trying to minimize swelling through management. We're trying to control pain, reestablish neuromuscular control, establish core stability, regain range of motion, restore muscular strength and endurance, regain balance and postural control, maintain cardio, which is a big one, and then incorporate functional progression.
I feel like that one sometimes gets forgotten.
The cardio?
Yeah.
I know.
Well, there's just not enough time sometimes.
I make them do it on their, like at the end or on their own time.
That's a good idea.
But we will talk about that. So we're going to break down each of these topics, and then we're going to go into building a rehab plan. We're going to be talking a little bit about immobilization, and then ending with some like rehab adjacent topics.
Ooh, nice.
So we'll see what we can get through. First thing is minimizing swelling. So obviously swelling is probably one of the most obvious things you can see after injury. I asked on our Instagram stories, what is your favorite way to help control swelling? And I did a poll where there were 4 options: compression and or elevation, E-stim, NSAIDs, and other. I actually was really surprised by these because 85% of people said compression and or elevation.
I vibe with that. I'm a big compression guy.
Like, what sorts of compression are you using?
In my head, the thing I thought of is like the pneumatic pumps, kind of like Normatex recovery pump, stuff like that. Even though recovery pump doesn't exist anymore. They were bought out by Therabody.
Oh, I actually did not know that.
Yeah, neither did I until my machine's not working.
Oh, okay.
But yeah, I've seen really great results with using that because it's basically I can set them up for 15, 20-minute lymphatic massage and I can go do something else.
That makes sense. I in my head, use intermittent compression as a recovery tool and not as a swelling limiter or swelling control device. So like this is so like beyond like I get it, but I think also in my head I'm thinking like if someone has an ankle sprain, like that's gonna hurt if they go in the compression.
That's why I really like the recovery pump one because you can adjust the pressure pretty low to where it should be very gentle. The one drawback with like the Normatex is in their intensities, they're pretty preset ranges and it's really hard to adjust for anything less. So that one I have to be a little more careful that they're a little further along before I put them in the Normatec boot.
That makes sense.
Yeah.
This also compression and or elevation can also kind of go with like milk massage.
Yes.
So Kelsey B says for excess swelling or stubborn swelling, I do lymphatic drainage massage followed by immediate compression sleeve so that it stays. I notice an immediate difference and can get more range of motion or pain-free exercise.
Nice.
My other go-to is lymphatic drainage KT tape.
Yeah. I like that one too.
Currently, I have on the back of my knee and it is working pretty well. The second most category was other.
Interesting.
11%, followed by eStim 4% and NSAIDs 1%.
Oh, interesting.
But honestly, most people who messaged us used a great amount of combination of things to control swelling.
Yeah.
So some of the more unique ones, I guess I shouldn't say more unique because here are some of the ones that I picked. Bre B says HivaMat. Unfortunately, my university doesn't have one, but the one that I went to did. It was great.
Yes, it is. Oh gosh, I wish I had one.
Yes, we love the HivaMat.
Big fans.
Honestly, I didn't know about it until you told me about it.
Yeah, I've loved it. It's made such a difference.
It's we did a deep oscillation therapy episode about it, so if you're interested, go check that out. Yeah, I feel like it's hit or miss if people have one or if they know what it is. But yeah, it really, really does help with that that lymphatic control. Ours is currently broken, and we definitely like our ATR has taken a hit from it.
Dang.
You want to read the one from Sarah Y?
Yes, I resonate with this one too. I like to do combo of compression and milking massage to control/reduce excessive swelling. I will use an ACE wrap or I'll power flex them for the remainder of the day because we know how ACE wraps and high schoolers go sometimes, LOL. It's so true. Sometimes those tube compression sleeves too. Ooh, I do like those. I don't have any, but I like those.
So I really love this because it also shows like you have to adapt it to the population that you're working with. And power flex as compression is so genius.
Yeah. Yeah. I mean, you gotta rock with what works.
And like inexpensive.
Yeah.
You can utilize it pretty easily. They can even undo it and redo it probably once or twice.
Yeah. And it's better than losing an ACE wrap.
Also, ACE wraps are ridiculously expensive for no reason.
Yeah. For no reason. Exactly. 100% no reason.
Gabby L says, I usually start with compression, but by day 2 or 3, I'll do biphasic eStim and apply KT tape to promote lymphatic drainage.
Do you like the biphasic?
I am obsessed with biphasic eStim. I don't know what I did before I learned about it, but basically, if you turn the frequency down on biphasic and you just get like literally like a pump, I'm sure if any given time you walk into our athletic training clinic and you will see someone on biphasic stim because it is so helpful for like spasm. It is helpful for fatigue. It is helpful for like recovery. It is helpful for swelling. I use it a lot for swelling. There's just so much that you can do with it. And so like when Gabby said that she uses biphasic eStim, I was like, yes. I didn't know many other people. Like I didn't know about it. So
yeah. What I like
until you told me about it.
Yeah. What I like to do, speaking of combining things, I like to do the compression boots with the eStim at the same time.
Oh, that's intense.
Yeah. So I like to do that, especially for I get the swelling control, but also I can start working on the inhibition too, instead of separating them.
Some people also message and were talking to us about like lymph nodes and like like working on the lymph nodes and then doing like milk massage.
That is supposed to be better,
Something that
especially
I've
with the Hiva mat.
oh yes.
Yeah.
Something that I've done is I've put a cup on the lymph node, like on the back of the knee, and then did a milk massage on the ankle to like really help promote that. And then I do an e-stim on peroneals to get that muscle pump. Yeah. And this one is actually pretty similar. Evan J says, I do compression and elevation with a firefly if I can. I usually try to do combo and massage the area as well.
Nice.
We also love the firefly. The creator is actually parent of one of our former athletes.
Oh, that's cool.
Yeah, so we have really, really loved using the firefly. And have got to use it a lot. Not really recently, actually, but we had people obsessed with them. But you can recreate it with a biphasic stim. You just can't wear it 24/7 like the firefly.
Yeah, for sure.
And that's the thing about the firefly is like you literally just put it on the outside of their leg and then send them on their way.
Set it and forget it.
Yeah.
Maybe don't forget it. You get it.
Another aspect of the rehab plan is controlling pain. So obviously pain can interfere with the rehab process. It can affect how range of motion is. It can affect also their gait or their exercises and how they're compensating with things. Also just the pain spasm pain cycle, which I use a lot in explaining to like my athletes what we have to do to kind of get out of. We have to get out of one of these things. And otherwise it's just going to be cyclical. So on our Instagram stories, I asked, do you typically start rehab with pain control or do you end with it?
I just start with it just because like what we've talked about in the past, the motor adaptations because of pain and inhibition. So I like to start with it.
Okay. You're with 26% of people. 10% of people said they do pain control at the end of rehab. But the majority says it depends on how much pain they're in and if they can get through the rehab.
I think that's the best athletic training answer ever is the depends.
It depends.
But if that is true.
Yeah, I know that I shouldn't have put it depends. I should have made you pick an answer. I think still at the beginning is what people mostly do. I would say I'm actually at the end.
Okay.
I say get through as much as you can. I mean, obviously I might do like a manual therapy or something else, but then I'll if they're not in acute pain right now, I won't do the stim until the end. Yeah. I guess actually no, I'm lying. Technically I am doing pain control in the beginning. Yeah. But I'm just like, I guess I'm quote unquote, I'm like making it stim. Yeah. But like I do some amount of pain control so that they can get through their rehab exercises. If they don't need that, then obviously I don't do that. So, but I would say I probably do more of the modalities and stuff at the end. Okay. Yeah, I mean, that's fair. Yeah, I feel like I do mine mostly at the beginning. But again, it does also depend. But I would say majority. Do you want to read this one from Kelsey B? Yeah, Kelsey says, with acute injuries, I almost always start with pain control. If I'm trying to get movement, but the athlete is in pain, I will often do movement in an ice bucket or bath cryokinetics. Yeah, I love cryokinetics. I've also done e-stim for a lot of shoulder post-op struggling with range of motion. Yeah, that's good. Mm-hmm. Yeah, I've done that. And doing that like with the stim on. Yes, yeah. Yeah, game 100%. Changer. I also asked how much pain do you typically allow in rehab? We got a lot of great answers for this one. Okay. I did a slider and most people slid it between the no pain at all and rehab should be painful. They kind of put it in between like the discomfort is okay. Oh, okay. I think most people are kind of on the same page about this. Lucas M says discomfort is expected. True pain is crossing the line. Mm-hmm. We want pain level to be between 3 and 4 out of 10. Any less is not enough load, and any more is too much load. Yeah, I mean, I would say I probably gravitate towards the no pain at all to discomfort. I think I'm in that range. Mm-hmm. There is sometimes that I'm like, they're like, oh, this hurts. I'm like, well, what do you mean? I'm like, oh, it just feels weird or uncomfortable. I'm like, that's fine. But yeah, I think that kind of pain level is a good way of looking at it, like 3 to 4. Yeah.
Yeah.
You know what's really helpful is like doing your own rehab. Like currently I'm nursing 2 injuries, and having your own, like feeling the rehab, and it's not it's always easier to make rehab and adjustments and stuff on someone else.
Yeah.
By yourself you're like, what is this? Like why do I do this for other people, but suddenly I can't figure it out for myself?
What the hell?
Right. But like as I'm doing my shoulder rehab, like I'm feeling like the resistance of the band, and like I'm feeling it in my shoulder, and I'm asking myself like, okay, if this was an athlete,
what would they say?
What would I tell them?
Yeah.
Can I keep going?
Yeah.
Or should I stop? Like how much pain?
Yeah.
You know,
is okay.
Am I compensating?
Yeah.
I feel like for me, it's really about, I don't really like getting them through pain because I want their body to move through a pain-free range.
Yeah.
However, I tell them discomfort's okay, sharp pain is not.
Yeah.
But because I mean, they do have to work through some. I'm not trying to get to that level.
Yeah.
But obviously, like I tell them like, you injured the area. It's just letting you know.
Yeah. I think this is another good one of it depends.
It does depend.
Because like
tendinopathies. I was just about to say that.
Like all those studies actually go to 7 out of 10 pain.
Are painful.
Yeah. I
tell them like this is the suckiest rehab because it's the only one that you're actually supposed to work through pain.
I mean, I'm still pretty conservative. Like I would say like 5 out of 10 pain. I don't like the go up to 7 out of 10 pain.
That's a lot.
I know. I feel like that's so much. But I do let them know like, hey, this one is supposed to be like fairly uncomfortable, but same thing. Like if it's like painful, like excruciating pain, like we'll modify. That's okay.
Right.
Yeah.
Want to read the one from Sam S?
Yes. Sam says, I explain rating pain on a 0 to 10 scale. 5 is where we compensate. Any exercise or activity I want to keep at a 3 or below. It tends to work great.
It seems like a lot of people use like the number scale.
Yeah. Which I think that's a fair way of like, hey, it's kind of uncomfortable. Like, okay, I'm okay with it.
Right.
Yeah. But I agree with you. Like, I'm not trying to get them like to go through, like push through, or like my basketball guys thug it out. Because also too, like we know moving in pain changes how you move.
Right.
And we're
I think
trying
that's
to correct
what I'm worried
that.
about. Right?
Yeah.
Jayde C says, I like to say to pain, not through pain.
Nice.
I tell them that discomfort is okay, but we stop and modify if they start complaining that something is painful. I also ask them, like, do you feel like it's making it worse?
Oh, that's a good question. I like that.
Like, if we keep doing this, do you think it's going to make it worse?
Yeah. Ooh, that's a good question. Should add that.
Or if we keep going, are you going to start compensating? I feel like they can answer that question pretty well. I work with college athletes.
Yeah. Well, also too, like I feel like they know, because like obviously they're gonna, if they know if they kept playing on it, probably they'd be like, yeah, this is probably gonna make it worse. They know the feeling of how does it feel to make it worse.
Yeah, I feel like it's something that I would expect them to not really be able to answer, but like they do a pretty good job.
Yeah, I like that question.
Another component is reestablishing neuromuscular control. And neuromuscular control, I feel like, is a word that we throw around a lot.
Oh, big buzzword.
But to actually define it, it's when the mind teaches the body to have conscious control of a specific movement. So basically, like the more that you rep something, then you don't have to think about doing it. So like I don't have to think about bending my elbow to bring my hand to my shoulder. Like I don't have to be like, okay, like bend up, right? I don't have to like think about it.
Yeah, that'd be awful.
Yeah, that'd be horrible. I can literally just be like, meh, and then like touch my shoulder, right? Yeah. So basically you can have less concentration needed to execute a task, and it becomes automatic. This is also why it's so huge right now, like all the dual tasking and the neuromechanic stuff that you're doing, like while you rehab, you have them do mind task or whatever, because then you can make that neuromuscular control quicker
Yes.
and more automatic quicker, and those pain-free motions quicker.
Yes, absolutely.
An example of what I do, I've said this before on the podcast, but we have, actually right now we're writing them because Happy National Athletic Training Month. I forgot to say it at the beginning.
Oh, here we go. Yeah.
So we have posters up on the walls that say I love my athletic trainer because, and then the athletes fill them out. And that's what we have like year round. We just make them in March. But we put them up and they're on our cabinets where the athletes do rehab. And so usually I use those as like they have to pick a poster or two or three and they have to read them backwards while they're like balancing or while they're like doing their rehab or like whatever, because like you read it forwards, like that's easy, but reading it backwards is a little bit more difficult.
I incorporate a lot of decision making, some of the dual tasking.
Oh, I like that.
Where like if they're balancing, I'm usually having them dribble, or I'm having them pass the ball. Sometimes I'll incorporate that with their like if they're doing standing hip abduction, I'll have them do that and dribble. Right, so then they also have to do a sport specific task. Another thing that I've been doing is like when they're balancing, I've set out like 2 colored like cones, and this is usually how I get the other student athletes to help me out. Is I usually tell them, all right, I'll grab someone else and be like, okay, all you need to do is shout out one of those 2 colors, and then the person balancing has to dribble to that side.
Oh, cool.
Yeah,
I like that.
yeah. And the student athletes get a kick because they get to yell red, green, really mess with their friends.
We do have some at the end. We do have some. How do you maintain like compliance with rehab?
Yeah,
and we have some pretty good ones.
That's pretty funny.
Yeah.
Also, too, it's fun to get like someone who's like not on that sport. So like I'll have a basketball player and like swims in there at the same time. So I'll have one of the swim athletes help me out with the basketball.
You're gonna be a matchmaker one day.
You know what? Maybe.
One of our off topic, but one of our posters that someone just wrote is, I love my athletic trainer because they give great relationship advice.
That's pretty funny.
Okay, so establishing or enhancing core stability is the next fundamental of rehabilitation. So, okay,
Emphasis
I don't
on
think
fun, by the way.
What'd you say?
Emphasis on fun.
Fun. What did I say?
Core stability is another fundamental.
Oh, I see.
Emphasis on everyone.
I really love core, but maybe not everyone does. This is so surprising to me. Like I always say in rehab, like, hey guys, like the reason why we really have to work on the hip is because like there's so many muscles that attach, but now I actually have a number. There are 29 muscles that attach within the lumbopelvic hip complex. 29. Damn. That's more than I thought.
Yeah, seriously.
Your extremity may be strong, but if your core is weak, there will not be enough force created to produce those efficient movements.
And there is evidence that supports that, by the way.
Yes, definitely. I'm sure there's a ton.
Yes.
So I did a slider for this one and asked, how often do you incorporate core in your rehab? Most people said about half of their rehabs.
Nice.
There are some skewed. Obviously, I am one of the skewers because I do core with probably 90% of my rehabs.
Oh, that's awesome.
Probably like some of the like wrist and hand I don't really like get there. But I do core with pretty much every rehab.
That's awesome.
Because it's so important, because honestly, like all these kids are lacking core strength.
Yeah.
Or even not
call
even
them soft.
Not even just core like crunches, but also just like bracing and just like ability to activate their deep core.
Yeah, well, that's what I do in my my class. Is when we talk about core, is we talk about how you should probably train the core, because that was a big topic when I was in school. Is right, like the core, when you look at the way it's like designed, right, it's probably not a super effective prime mover. Like my greatest example is if you look at like the rectus abdominis, right, you see these like pockets of muscle. well, if that was designed to like do this huge movement, why not just make it
one big
muscle?
Yeah.
All right. So it's really designed for that role of stabilizing, being able to activate and relax effectively.
I never really thought about it as pockets of muscle. That's a really interesting thought.
Mm-hmm.
So, of course, I asked what people's favorite core exercises are, since people are doing it with half of their
About
rehabs.
half, yeah.
The number one answer was dead bugs.
I mean, that's a classic. And it's easy to do.
Some people added bands. Some people added a ball.
You can do a lot.
I really like doing it with a ball.
Where?
Between the knees and the forearms. So like they're squeezing, like they're gonna do a sit up, but they're like squeezing the ball between their arms and their knees.
Another one to do with dead bugs, like this is pretty advanced, but use a BOSU ball, and you basically have them lay on the ball part, and then they do their dead bug.
You know what? I used to do this with my performing artists, but I tried to incorporate it in the setting that I'm in currently, and I have not found someone who has been able to do it yet.
Do it. I know. It's hard.
Yeah.
It's hard.
Yeah.
But
man,
it was like it's humbling.
It was a staple.
Yeah.
And when I was working primarily with performing arts.
Yeah. It'll humble some people.
Yeah. Yeah. I mean, maybe that's also like background. Like we do a lot of core in performing arts.
Yeah.
Pelvic neutral / bracing / TA activation fell just under dead bugs. This is probably the one that I incorporate with most of my rehabs. You can add marching. You can progress into quadruped. You could do it seated on a Swiss ball. You can do it seated on the table. You could do it standing. Like literally just, and then it becomes,
you do it anywhere.
And then it becomes start with this and make sure you do every single rehab exercise with this. It's also something I tell them, like wake up, roll over, start doing these activations.
Yeah.
If your hips are moving, it means you're not activating right.
Yep. Nope.
The next popular one was Palloff press.
Oh yeah, that's a good one. I like that one a lot.
I really like that one too.
You can also add so much to it.
Yes.
Right. You can add certain exercises to it. You can add like lateral walks with a Palloff press. Yes. You could do there's a ton you can do.
I really like the lateral walks. You could also do like a cable rotation at the end. Planks and side planks were I put that out of order. Planks and side planks were actually above Palloff press. You can do so much with planks and side planks. You can add abduction or clamshell when you're in side plank. You can add a BOSU for an unstable plank. A lot of people said one of my favorite things, putting the tennis ball on the BOSU on the flat part, and then having them like make circles with it, or trying to get the tennis ball to the center of the BOSU, or it just makes it fun. Copenhagen planks were really popular. They are tough, but they're tough. So good.
Yeah.
I didn't know that's what they were called, so I had to look them up. But then once I realized that's what they were called, I use those. Plank with a dumbbell pull, and then also like bear crawls with sliders.
Yeah, nice.
Rotation and anti-rotation, anything were next popular. So med ball rotation slams, anti-rotation dead bug is a big one. Kettlebell around the world.
Yeah. Oh, yeah. That's a good one.
Next is bird dog. So you can also do cat cow. I kind of forget bird dogs is a core exercise. And I think you really have to cue it right, because otherwise I think it can be done pretty.
They just do it.
Yeah. But if you pair it with like a TA activation and have them like learn. And then when we were at NATA last year, someone explained bird dog. If you, instead of just like lifting your leg in the back, like take your foot and press it like you're stepping on the back wall, like the wall behind you. Yeah. I love that cue.
Yeah, that's a good cue.
It's a great external cue.
Yes.
And it really makes you get your posterior body instead of just like, and it doesn't really get that arch of the back as much.
Yeah, that's a good way.
Just think about like stepping. That. Yeah, I really, really like that one. The next couple, these are the last few: lunge with chops, weighted carries, and I already said that one. and yoga ball stir the pot.
Stir the pot's good. I like stir the pot.
That one's so hard.
If stir the pot, what I do if stir the pot is hard, I'll break down the movement, and they can do like saws.
Oh, I like that.
Or then you can progress to side, and then finally you could probably add stir the pot.
It's basically like a cheap Pilates reformer.
Yeah, you're right.
Okay, so next up in rehab, we have regaining or improving range of motion. So there are two main types of motion that we're talking about. You can have like a physiological muscle.
Yeah.
And then you can also have an accessory joint. So if you have muscle tightness, it could be like contracture of connective tissue. So what are you going to do with that? You're going to stretch, you're going to do manual therapy. But if it's range of motion lacking coming from the joint, like if there are joint restrictions, then you're going to want to do things more like joint mobilization, stuff like that.
Yeah, for sure.
So we do have an ATStudy Buddy quiz break. So this is a question that Allison gave to us that is an example of something that you might find on one of their practice exams, which the practice exams do give you instant feedback. So we're going to work through this one. While performing passive range of motion testing, a clinician notices a sudden painful bony block during knee extension. What type of end feel is this, and what does it likely indicate? A, abnormal hard end feel, possible osteoarthritic changes. B, soft end feel, hamstring tightness. C, firm end feel, normal capsular resistance. D, hard end feel, typically bony approximation. Or E, spongy end feel, joint effusion. So working through that, the first thing I'm noticing is I go back to the question and it says a painful bony block.
Also sudden.
Sudden, yes. Yeah. Painful bony block. So the options are remember there's two parts, right? So there's the end feel and then the reason. So let's look at the end fields real quick. So we have abnormal hard end feel, we have soft, we have firm, we have hard, and we have spongy. Well, bony block doesn't sound spongy to me.
Or soft. It
doesn't sound soft. So it's probably abnormally hard, firm, or hard.
Yeah.
When we look at firm, which I feel like is the softest of those, it says normal capsular resistance, which if we're feeling a bony block, I feel like it shouldn't feel the same as like a capsular resistance.
Also painful.
Right. So I think that we can take that one out.
Yeah.
So now we're either at hard end feel or abnormally hard end feel. Now, one of them says it's a typical bony approximation, and the other one says possible osteoarthritic changes. Now, when we go back to the question, it says a clinician notices a sudden, like Randy said, painful bony block. So if it's painful, it's probably not going to be a typical bony approximation, right?
Yeah.
So our other option is abnormal hard end feel, possible osteoarthritic changes, which is the correct answer.
Yeah.
Okay, moving on to rehabilitation, restoring or increasing muscular strength and endurance. This is actually the most obvious, and we're going to talk about this more as we talk about developing a rehab plan. But one of the, again, this is kind of obvious too, but isometric, concentric, eccentric are really what's making this up.
Yeah.
Isometrics are useful when like a full range of motion might make that injury worse. So you can just work strength in the range of motion that you have.
Yeah.
It can also help lessen swelling due to that muscle pump action. So this is something you can do like early on. An anonymous person says, my favorite isometric is an iso knee extension for patellar tendinitis. I wrap a 10-pound ankle weight and use my body weight to resist the knee in 60 degrees of flexion. Goal of 70% 1 rep max effort.
Nice.
Hold for 40 seconds, rest for a minute, and 20. Repeat 5 times. This has done wonders for patellar tendinitis with immediate results.
Oh, that's awesome.
Yeah. The concentric and eccentric specifically is more important for like deceleration of limb motion.
It's about control.
Yes. So, but we'll talk about those more. Regaining balance. So a lack of balance after injury may limit the patient's ability to respond / self-correct when their body becomes off balance. And we all know that if you don't have good balance, that increases your risk of injury. So I also asked how you incorporate balance within rehab. A lot of people said things like changing vision, adding functional stuff. A lot of people also talked about how it's better to challenge the body a little bit more than it is to challenge the unstable surface, because I know that like the research isn't like so good on the unstable surface, especially translating to sport. I think it is still important to do some unstable surface stuff, and it does make it harder, but if you're trying to get function, probably stick more to like making it more like challenging functionally and challenging them like that. A great way you can do this is from Kelsey B, if you want to read this one.
Yes. I have the athletes incorporate a roller coaster point of view. There are some good videos on YouTube. I've casted it to the TV and had them watch it, or just put my laptop at eye level. Sometimes I do it just for a fun variation, but I also do it to do it post-concussion to help with the vestibular system, which that idea of the roller coaster point of view is actually really good for kind of changing the motor system after injury as well. Especially like post ACL, because athletes tend to use their eyes more now to guide their movement.
Obviously, because they're lacking neuromuscular control.
Yeah. And doing this helps break that, because now they're responding to the environment instead of like watching their knee.
So I really, really loved that one.
Yeah, that one's a good one.
And I might actually start incorporating that.
You know what's funny is where I work, they actually have like a like an esports kind of area in like the library that have the VR, and you could just like book out time. I want to try and do it.
Oh,
so I can take athletes over.
Wow, that's really cool.
Yeah, but obviously time wise, sometimes it's hard. but during the summer, I can do it.
I also asked in our broadcast channel, which we're kind of new to, but it's basically like, and we don't spam messages. We literally only message when I put story prompts up. So if you ever want to know when we put story prompts up, join our broadcast channel. It's on our Instagram story, on our Instagram page. It says submit your story. So then you just join the broadcast channel, and then every single time I put up prompts, which is maybe like once or twice a month, then you will get a message that says the story prompts are up, because they're only up for 24 hours. So if you don't want to miss those, make sure you join this. I also put in some bonus questions in there. This time I put, how do you make balance exercises more difficult? And a lot of people said you can move your head, move your eyes, add a ball toss. Ball toss was really popular. Dual tasking was popular. You can also add a body blade, which I've never thought about, but that's a really good idea. Manual perturbations, other limb movements. You could do banded resistance while you're balancing.
Nice. Yeah, I've done those. Honestly, a lot of balance stuff too is just doing single leg exercises.
It is.
I've done a lot of single leg to just incorporate balance without it being a balance exercise.
Yes. I really like cone taps. Someone said, love to put cone taps in a circle around them and have them touch each one. It's one of my favorite exercises. That's personally also one of my favorite exercises. Because I feel like it's not just like, okay, go stand over there, close your eyes, and hang out.
I agree.
Okay, so moving on to maintaining levels of cardiorespiratory endurance. Remember that when they are not participating in their sport, obviously their cardio is decreasing. So they have to be doing alternate activities that are still safe for their injury, so they can maintain their existing levels of fitness as best as possible. How do you keep up cardio for athletes when they're injured? Most people said bike, pool, rowing, elliptical.
Yeah. It's all pretty good.
Yeah.
Those are all pretty common, I'd say.
Yeah. I couldn't really think of how else I do. I would say I use the pool and I use the bike. I use the bike a lot.
Yeah. Yeah.
Which is funny because personally, if someone told me to bike, I'd be like,
it's awful. I get it.
I don't really like on the bike, but athletes just love it.
Really?
I
don't think my athletes usually complain about it.
Really? I don't have athletes complain about that.
They hate the bike.
They'll come in and be like, "Can I use the bike?" I'm like, "Yeah."
I've had people want to do it as a warm up. Like just they pedal for 2 minutes and they're like, all right, more. But if I had to give someone a bike workout, most of the time they're like, I mean, I guess if you're out for a long time, they're like, oh, thank God I could do something. But
yeah, I have them do intervals, or I have them just do regular biking. If like, let's say a hamstring injury, like I'll have them, if they're ready to jog, I'll have them jog on the track. And then instead of doing sprints on the field, I'll have them do sprints on the bike.
Nice.
So it's kind of like a trade-off.
Yeah.
Okay, so now we're getting into, those are all the components of rehab. Now we're kind of getting into what happens after injury. So sudden physical activity after injury, and remember this, we just kind of talked about it, was the cardio. It's going to cause a rapid generalized loss of fitness, muscle strength, endurance, and coordination. Yeah. And this is also really important to notice when we have immobilization after injury, because even after 24 hours of immobilization, you start to see changes at muscle, joint, ligament, and bone. Yeah. So at the muscle, you can see an atrophy of the type 1 slow twitch muscle fibers. And this happens mostly in a short position immobilization. So like if you have them like plantar flex, for example, and their calf is shortened, right? So whenever possible, you're actually, it's actually recommended that you keep the immobilization in a neutral or lengthened position to help kind of prevent that muscle atrophy.
For sure.
And if you do see that muscle atrophy, you can do isometric contractions, and you can also do electrical stimulation.
Nice.
Like we talked about before. At the joint, you're going to see a decreased joint compression because you're not obviously compressing the joint as much, which we know that when you compress a joint, then you get like synovial fluid and lubrication, especially the articular cartilage needs all that. So if you stop doing that, that's going to be detrimental for especially the articular cartilage. Yeah. So some things that you can do, this is why it's so important after surgery, if they give you a CPM machine.
Dude, it's funny that you put that in there. I have not seen one of those in forever.
Wait, really?
I've not once have my athletes said that they've been given one. And like, I have not seen one in forever, it feels like.
You know what? I was thinking that too, but my athletes do get one after surgery, but sometimes they just don't talk about it.
I would be surprised because like I feel like I'd want to talk about that. Like, yeah, do I have this thing that just moves my knee? It's pretty cool.
Yeah, I really thought that they were also kind of outdated. Yeah. But like literally the pictures that the athletes show me look exactly like the ones from the 80s. Like they have not changed. They like the little puffy thing.
Well, it's a good design.
The little fluffy thing.
Yeah.
Still there.
Well, you gotta make it comfy.
You can also do stim to help with this, and hinge braces to help protect the joint but still optimally load the joint. And then ligament and bone, these become weaker due to lack of stress. Obviously, due to Wolff's Law, because bones will adapt to the stresses placed upon them, aka patellar tendon, or oh my gosh, why am I forgetting the tibial tuberosity?
Osgood Slaughters.
Thank you. Wow, that was a brain fart. Osgood Slaughters or Seaver's disease at the back of the ankle.
Oh yeah, Seaver's.
Some things that you can do to help prevent this or treat it are high frequency, short duration endurance exercise, because that will help the bone. So we have another question break from ATStudy Buddy. Do you want to read this one?
An athlete trainer is working with a post-surgical patient who has experienced muscle weakness and swelling in the affected limb. To aid in the recovery process, the athlete trainer incorporates electrical stimulation therapy as a part of the treatment plan. Which of the following are treatment goals associated with electrically stimulating muscle contraction? And the BOC's favorite, choose all that apply.
Yes. So we have the question again, which of the following are treatment goals associated with electrically stimulating muscle contraction? So motor stim.
Yep.
Okay, go ahead and read the answers.
So we have decreased swelling, increased muscle strength, improved cardiovascular endurance, slow muscle atrophy, muscle re-education, enhance bone density, and finally promote relaxation of overactive muscles.
So go ahead and pause this or whatever. Try to figure out what you would apply. Some things that we've talked about in the episode before are decreased swelling.
Yes.
So we talked about that in the very beginning.
Mm-hmm.
Electrical stimulation, especially motor stim, can help with that motor pump.
Yep.
That muscle pump to get swelling out. Increased muscle strength, we didn't really talk about. I guess you can if it's more of like a Russian or a NIMS.
Yeah.
Improve cardiovascular endurance. I don't know about this one.
Oh, the cardiovascular endurance. Yeah, that one seems weird to me.
Yeah, that's surprising, but it does have that listed as an answer. So,
yeah.
Maybe look into that.
Yeah, seriously, I would be intrigued to see where that's coming from, or like what's the research behind it.
Mm-hmm. Slow muscle atrophy. That one's also one of them, and muscle re-education.
Yep.
And we just talked about muscle. Yeah. Okay, so now we're moving on to what I think we've probably been waiting for: developing a rehab plan.
Heck yeah.
So, other than prehab, so prehab is like before operation surgery, right? Pre-op. Basically, the more prehab you do, the better outcomes you'll have post-op.
Heck yeah.
This should include things like you want the initial inflammatory phase to resolve. You want to maintain muscle strength, flexibility, cardio, and neuromuscular control, which is a highlight topic of this episode. Some favorite things that people have included are balance, proprioception, contralateral limb work, breath work, cardio, core strength, range of motion exercises, ISOs, BFR, and gait training. So past prehab, there are 3 main phases in a rehab plan. The first phase is an acute inflammatory response phase. The second phase is a fibroblastic repair phase. And the third one is a maturation remodeling phase. So the first phase is initial injury to 4 days. So the body's goal is to control and clean up these injured tissues, whereas the clinician's goal is to help control that swelling, modulate pain.
Yeah.
We already talked about some of our favorite things to do there. Optimal loading to an injured body part is critical during this phase. If you're too aggressive, then the inflammatory process doesn't fully complete. Yep. And then the length of time that the body is in that inflammation phase will be extended.
Yes.
So I also asked on our Instagram stories, how do you know when you were too aggressive in rehab?
Oh, that's a good one.
The book says you're going to see an increase of swelling, increase of pain, loss of plateau in strength, loss or plateau in range of motion, increase of laxity.
Yeah.
The responses that I got from everyone are very similar. The most common was pain that lasts over 24 hours later. Increase of pain, soreness, discomfort in general, increase of swelling, and then change of movement pattern.
Yeah, I agree with that. I agree with all those.
Yeah.
That's what I look for.
Right. Also remember in this phase that uninjured body parts do not need rest.
Yes.
So you want to continue the cardio, strengthening, flexibility exercises for parts of the body that are not affected by the injury. Sometimes this like befuddles the athletes. They're
I know.
Like, what do you mean I can still go to weights?
Yeah.
Why are you? Why are you fighting me? You want to be back in? Like.
Yeah. Go to weights.
Yeah. Isometrics can be done for immobilized body parts. I think we've said that like 8 times already. So repetition is key. Around day 3 or 4, you can start doing like active mobility exercises. Again, these want to be like a pain-free range of motion. And then also you want to encourage them to progressively bear more weight.
Yeah.
If you really need it, you can use NSAIDs to control swelling and inflammation.
Yeah.
Another ATStudy Buddy question break. Which of the following interventions can be used by athletic trainers to help manage pain according to the gait control theory? Select all that apply. A is gentle range of motion exercises. B is application of ice. C is anti-inflammatory medication. And D is electric stimulation to increase neural activity. Oops, one more. E, functional strength training. So we talked about managing pain. Gentle range of motion exercises, probably not the best answer to manage pain. Application of ice, the main premise of ice is to decrease pain. So I would say that's a good answer. Anti-inflammatory medication sometimes has pain relievers in it, but if anti-inflammatory medication is the primary, I wouldn't say that's probably to manage pain.
And also the particular kind of theory that doesn't really align.
You're right, because we're talking about gait control. Gait control. Thank you, Randy. See, using the question. Electric stimulation to increase neural activity. That sounds pretty good to me, since electric stimulation does help pain and gait, and it literally does it through the gait control theory. And then functional strength training. I would not say that helps manage pain. So application of advice and application of advice, is that what I just said? Ice and advice, baby. Yeah, application of ice. I almost did it again. And electric stimulation to increase neural activity. Sweet. So phase 2 is the fibroblastic repair phase. This lasts from 4 days to several weeks post-injury. The body's goal in this phase is to create basically scar tissue by the fibroblastic cells are going to lay down the collagen matrix. This is when like swelling has stopped. And so there's going to be less pain with like active range of motion, passive range of motion, palpation. Our goal at this point, so the clinician goal is going to be, again, maintain that cardio. We're still focused on this, maintain that cardio. Restore full range of motion, restore or increase strength, and reestablish neuromuscular control. This, you can also use modalities to control pain, swelling. You can use like cryotherapy or electrical stimulation. I feel like we just had a question on that.
Yes, we did.
And then phase 3 is, this could take up to several years, but this is ultimate goal, return to activity. And obviously we're probably going to return for the most part before several years. But even after you return, you're still getting maintenance, and your body is still undergoing remodeling. So the body's goal is going to realign these collagen fibers according to tensile stresses placed upon them during functional sport-specific exercises. So our goal to back that is to regain sport-specific skills through performance of dynamic functional activities. This is where you can really make your aggressive active range of motion exercises, aggressive strengthening, plyometrics, you want to increase that muscle power and explosiveness. This is where you're going to want to do more functional testing. You can also really get aggressive with those heating modalities so that that are specific to the deeper tissues. So like ultrasound, diathermy. You can massage or use mobilization to reduce spasm, increase circulation, and reduce pain. And then also just in general, you want to get good blood flow, since this brings good nutrition to the tissues and helps increase the lymphatic system. Its job basically to take out the waste.
For sure.
So now I kind of want to move into those functional progressions. So once you've rehabbed past that normal strength, you really have to do like functional and sport specific. You can't just be like, here's some rehab that you do in the ATR and then bye.
Go to the field.
Right. You actually have to do those sport specific things because not only is it going to help them get back to sport physically, but also like mentally. They are going to feel like, oh, they're ready. They're not going to feel as apprehensive because they've done these in a controlled environment before. And then they can actually return to be competitive.
Yeah, for sure.
So I asked for people to send us a progression of functional activities that they've done. And the example that I gave, so football defensive end, they don't just run in a straight line, right? They have to like get around people. So a lot of times, and it depends on like what end they're on, but like A lot of times they're like going at an angle, so they're not like at that flat, and they have to make a really tight turn, right?
Yeah.
So after their normal strength gains, like after our normal like strength everything, what I did was actually, this is in general what I do for like an ankle sprain for DNs, because I feel like we see that a lot. Enough that I get these functional. I do this a lot. So split squats with the front leg up on a slant board.
Oh, okay.
Just anything that we can really get that ankle at an angle. Whoa, those are very similar words.
Say that 10 times fast.
I really like, this is one that I use a lot. I'll have them like lean up against the wall. So almost like they're doing a side plank, but their hand is on the wall.
Yeah.
And then I have a band around their feet, and I do like marches, like switching. So then they'll do like, kind of like an explosive, like, switch, like of their knees, like high knees, switch, like high knee switches.
Yeah. That's pretty cool.
And then on the field, we're progressing to doing like a large hula hoop drill, because they have to like run around a hula hoop. Like do like a really big one, and then do a smaller one, and then a smaller one, and then finally do the actual hula hoop.
Yeah.
Because their body is at an angle.
Yeah.
And then also, this is also where I tell the students, like, when you go to practice, pay attention to their drills, so then you know what they're doing, so that you know what they have to do, because then you can use that to your advantage.
Yeah.
Christina S. So I did take 2 of the examples that we got, and I put them in here. Christina S. says she has a cornerback with a hamstring strain, and he needed to be able to sprint and cut. So after getting his hamstring feeling pretty good, we did a lot of ladder drills for explosiveness and cutting. We added some broad jumps and some B skips, and then progressed into sprints.
Nice.
Starting at 50%, going up until he felt a little resistance from the hammy. It really helped him understand where he was at, and allowed him to make the decision he wasn't ready for a return to play yet, when he saw that he couldn't get to full speed.
Yeah.
This is huge. I always start people at 50% with hamstrings and any sort of sprint progressions. And the it makes it so easy when I can tell coaches and the athletes, like, oh, they're about like 70%, like we're still working through.
Yeah.
Where like it's a little bit more objective, and they understand, like, oh, I'm not 100%.
Yeah.
Like I'm not full speed yet.
I think that's what's important. It's making sure that it helps your process when they realize, oh, I'm not ready yet.
Right. And then you're on the same page.
Yeah.
Yeah. I really like this. You want to read the next one from Annaliese L?
Yes. Annaliese says, I work in the military setting, so a lot of my progressions are related to load bearing. Athlete with low back pain, chronic. Basics started with TA contraction with glute bridge, TA contraction with supine marching from hook line, TA contraction in plank on a plyo ball, TA with a waiter hold, TA with marching in place, TA with forward lunge, dumbbell hold, lunging with weight over shoulders, barbell or front rack position with kettlebells, to weighted vests, step up, to weighted walks, increasing duration, intensity, and weight. A lot of TA. I like it.
The transverse abdominus can be progressed into everything.
It's nature's weight belt.
Oh, I guess that's true. Yeah. I use a very, very different analogy.
Yeah.
I call it the corset muscle.
I mean, it looks like that, but it also looks like a weight belt. So usually when I tell athletes that, they're like, oh.
I feel like athletes would probably relate more to your analogy than mine.
Well, at least maybe like athletes that tend to lift bigger, I guess. I don't know. Like my throwers would probably get it more.
I like it. Maybe I should start using that one. But yeah, you could totally like see how it started with supine, and then moving into prone, moving into seated, moving into standing, and then walking.
Yeah.
Good progressions. Okay, so I have 2 more rehab adjacent sections. One is aquatic exercise, because aquatic therapy is so great. I want to know how many people actually use it in their rehab. And according to the poll that we did on our Instagram stories, now, of course, this is not all 56,000 athletic trainers, so I have no idea how scalable it is.
Could you imagine, though?
I know that'd be amazing. But we do have a good couple hundred who responded, and 58% said they don't have access to a pool.
That is going to be hard.
Yeah.
It's going to be hard to do aquatic exercise without that.
Yes. So, but even with that, we did have 26% of people who said they do aquatic therapy and 16% of people who said no. Emily M says, in the past, when I had better access to a pool, I would do pulls using the upper body, which is like not kicking to go across. You can use noodles or floats to help support the body.
Yeah.
And then you can also just hold onto the side and flutter kick, turn to the side, do frog kick, etc.
Yeah.
And then you can also do a pool for great team recovery.
Yeah, for sure. I actually just this past week, one of my ACL post-ops, we did some just...
You finally made it to the pool.
Yeah, well, luckily I have a student, so that was their opportunity to practice aquatic exercise.
Nice.
Yeah. So we did we did some gentle range of motion and
nice.
Yeah, because they're fairly early on, but obviously it's safe for them to be in the water. So we just did gentle motion.
Nice.
And it was something different than just the same old, just do your heel slides. And
I think we should do an episode on aquatic therapy. We did actually our second episode ever. I think it's the second episode.
I think so. That's a throwback.
With Haley, who is my first preceptor. She used to teach aquatic therapy. So we did an episode with her. But now we are 6 years later, and I think we should probably revisit that. I use aquatic therapy weekly. It is something that I am so lucky to have a pool. We do it a lot for our teams for recovery. Probably a couple times a season per team.
Oh, that's nice.
At least we have definitely the basketballs, definitely softball, football's got in there before.
Oh, nice.
I'm trying to remember who we do it with most, but anyway, and I have a couple guys who come weekly to do and we schedule it, and
that's nice.
Yeah, we'll talk more about that when we do an episode.
That'd be dope.
Because I think there's so much that you can do.
Oh, 100%.
Because really in there you can do sport specific, you can do resistance, you can do full body, you could do cardio. Endless.
Yeah, absolutely.
And lastly, I want to talk about adherence to a rehab program. This is important, obviously, because if you can't get them to come back, how are you going to get them to rehab?
Yeah. Yeah, not wrong.
So I asked how you get athletes to stay compliant with their rehab. Kaetlyn H says, I always try to add some type of competition between athletes. Who can do their lateral shuffles while keeping form the fastest? And they have to start over if their form drops. Or if we're working on single leg landings, play tic-tac-toe. You have to jump into... Oh, I really like this one.
Yeah, that one's a good one.
You have to jump into a single leg landing in the box you want.
Yeah.
If you lose balance, it doesn't count. Wow,
nice.
I'm going to steal that. That's so good. Some other people say choices. I let my long-term patients choose which form of conditioning they want to do, and it makes them more likely to want to do it.
Yeah, I like getting their I like getting the athlete's input into their rehab.
Include them in your rehab planning. It's on you to actually get better. Keep it simple. 3 to 4 exercises a day is the sweet spot.
Honestly, yeah, I try not to give them a ton. I mean, obviously for like my post-ops, like unfortunately, like we're going to be doing a lot.
Yeah.
But like for the most part, like the everyday things, like I really just, especially time wise, right? I'm not trying to take up all their time. Like I know there's students too, and like they have a time crunch. So like I just try to pick, those good 3, 4, just what are the most effective things that I can get.
Change up their rehab. Some environment things. Comfortable environment. First one in the ATR gets to pick music for the day. Keep a candy bowl in the office.
Oh, any snacks.
Yes.
They love that.
Yes. Those go very quickly.
Yes, they do.
We do not keep snacks very long. Sticker charts for each goal achieved. I used to do that with, I used Canva, and I just made a little like punch card, a rehab punch card.
Yeah.
And for one of my athletes who was like, I'm going to come like every whatever.
Yeah.
And I said, okay, every single time we're going to mark off. And then once you get to the end, then you get to go buy yourself a root beer float. Like that's what you're.
Yeah, that's fine.
Sorry, I'm not going to buy it for you, but.
No. No.
It's your
it's your way of
motivation
celebrating.
Go celebrate yourself.
Treat yourself.
Yeah, I think actually that's what it said on it. It said treat yourself, like right at the end. And then there was a picture of
That's pretty funny.
Float. Anyway, I think that's really the majority of. Oh, I was gonna say, my rehab very similar. Like I have my rehab, what is that thing called? Sheet. And then I write out the exercises. I give them more than they need.
Yeah.
But I'll give them like 4 glute exercises and I say pick 2 for the day. Or I'll give them like 6 hamstring and I say pick 2 or 3 for the day. So that's our BOC in real life. If you want to hear more BOC IRL episodes, we actually have a decent chunk now.
Yes, we do.
I would say probably 5 or 6 of them. I don't know off the top of my head. Again, check out ATStudy Buddy. There's more information in the show notes, and if you want to take advantage of that discount, make sure you do 10% off the monthly subscription using code ATCornerStudent. Here on AT Corner, we also do other episodes other than BOC episodes. We also do episodes that are story episodes, traditional story episodes where we take stories from athletic trainers on highlight topics, athletic trainers from around the world, which I think is just super cool. Super cool that we get to do that. We just provide the platform and you guys just really come together and it's awesome. We also do CEU episodes that Randy heads. Randy reads a ton of research articles. I don't think you guys understand how many research articles this guy reads. And he somehow synthesizes them and we talk about them conversationally and then you get CEUs for it, which is awesome. And then we also do interview episodes where we bring in experts on their highlight topics. And I think that's really the basis of it. I don't think I have anything else. You got anything else?
Nope. Thank you for helping us showcase athletic training behind the tape. Bye.